Do you really need a statin? Should you get a calcium scan? And why are doctors suddenly talking so much more about Lp(a) and ApoB? Yeah, they are heart tests. Today we're breaking down the brand new heart guidelines and what they really mean for you. Hi everyone, I'm Barbara, and this is Age Better. Heart disease is still the #1 killer of women, and yet so much of the advice around prevention can feel confusing, inconsistent, and honestly, hard to translate into real life. My guest today is Dr. Anthony C. Pearson, a leading cardiologist who started the Skeptical Cardiologist on Substack. I love his Substack so much, it's great, which is highly recommended. I've wanted to have him on the show because he does something I truly appreciate. He looks closely at the evidence, questions the hype, and helps people understand what really matters when it comes to protecting the heart. Once Dr. Pearson agreed to come on the show, I made a huge list of all the things I wanted to cover, but then we would be kind of chatting for hours and hours and hours, so I had to kind of narrow it down a little bit. So today we're talking about the new cardiac guidelines released in March of 2026, what changed, what women over 50 need to know, and why some of the tests that I've been talking about a lot on this show for years and nagging you all with love in my heart to get, specifically the calcium score test, the Lp(a) test, and the ApoB test are finally getting stronger attention in the mainstream guidelines. And the Skeptical Cardiologist is going to give us the real scoop. Okay, everyone, get ready to age better. Dr. Pearson, welcome to Age Better.
Hello, Barbara. Good to join you here. I'm a big fan of your podcast.
Well, thank you so much. I just hope that every conversation I have, like with people like you, Dr. Pearson, that my audience learns a little bit more and becomes more knowledgeable about how to age better. Now, let's talk about the Skeptical Cardiologist on Substack. And everybody, there will be a link in the show notes so that you too can check this out and subscribe. But where did that name come from? And why is it so important right now to really be even more skeptical about a lot of the health and wellness information that's out there? Tell us the backstory.
Yeah, well, I think that all good scientists are skeptics. And a skeptic is someone who questions the information that is given to them and doesn't just accept everything as truth without looking into it themselves. And I've always had a skeptical nature, but going through my cardiology medical training, for the most part, I accepted what I was told as being the truth without looking back at the original scientific studies, for example, or looking in depth at how the information might be biased or might not be accurate. And then the Skeptical Cardiologist was born when my beliefs about nutrition were challenged by my then fiance. I called her my eternal fiance. As we were having lunch, she ordered a croissant and proceeded to slather butter all over it. And I was shocked because I had been following the guidelines that I had been taught.
Nixay on the butter.
Yeah, since the 80s, we've been told low fat, and you should be consuming low-fat dairy, and you should definitely stay away from butter. And putting butter on a croissant is doubling down on it. And she challenged me on that. And so I proceeded to look at the primary data in this area, the scientific studies, and none of them actually supported that dairy fat was bad for you. In fact, it's associated with lower cardiovascular risk in some studies, lower risk of diabetes, and dairy fat in yogurt is cardiometabolically very healthy, as is that in cheese. So ultimately, I realized that even though the guidelines, the AHA guidelines, the ACC guidelines, all nutritionists were saying this, it was wrong. And it caused me to have an epiphany and start challenging pretty much every received wisdom that was given to me to make sure that my patients weren't getting procedures or devices that they didn't need, even though the guidelines might say they were indicated, and to look into pseudoscientific things and to look into drugs in more detail and understand. I spent some time in academia. I spent some time in private practice, in big private practices, and I saw all the biases that creep in all of these areas with industry ties, with the need to publish. And so I write on those things from a skeptical standpoint.
Right. You know what's so fascinating, and of course I know you'll agree, it's such a wonderful thing to be able to access information now, especially medical health, wellness information, just by going online. And there's some very good sources and resources, of course. I mean, especially if you go right to the organizations like the American Heart Association and so on. And of course, to the Skeptical Cardiologist, for example. But first of all, it's so much information. And then every day you see like a new study comes out that contradicts what was already assumed was correct information. So it is very confusing. I'm sure it's confusing to people in the medical community, but it is really confusing to people like me and my audience. So regular people who are just trying to do their best and eat the right things and not eat the wrong things and so on and so forth. So that's where I really feel that your information is so important. And there are new guidelines now, which we will be getting to in a few minutes. But I just want to point out that what you already know, my audience is primarily women, 50 and over, 60 and over, midlife women who are eager to get the right information, not to be overwhelmed by it, but just like, hey, tell me what I need to do. What should I be eating? What should I not be eating? How should I be exercising at this point in my life? Because as we know, our bodies change as we get older. And I believe in this whole big thing. It's like my mantra, reassess and tweak throughout your life. What are some of the blind spots that you see women like me have, especially as it comes to heart health? So let's narrow it down to heart health.
Sure. I would say that the number one blind spot for both men and women, and probably a little bit more for women, because cardiovascular disease is the biggest killer of men and women. And most women, according to surveys, don't recognize that it is that biggest killer of women. They think it's cancer, breast cancer, but it's still cardiovascular disease.
Big blind spot. Big blind spot. Still, which kind of amazes me.
Yeah. And I would say related to that is I see a lot of women and men who feel that if they are exercising regularly and feeling fine, not having any symptoms, not smoking, eating a healthy diet, and keeping a good weight, that they are not at risk for heart attacks. And that's just not true, because as we'll talk about, the thing that causes heart attacks, atherosclerosis, builds up silently, and the first symptom can be just a heart attack and dropping dead. So that is something that misbelief can contribute to very early, premature, and unnecessary deaths, I'd say.
I think this is probably a great time to segue into the new guidelines that have just come out recently, which you did write about already in the Skeptical Cardiologist on Substack. And thank you for that. But they really changed in a very big way. Can you first give us a little, and then we'll get to some of these tests that really we all should be getting. And I know that you recommend them and you agree with, I think, most of what the guidelines are now saying we should do. So let's start with that. Just tell us a little bit about the highlights from the new guidelines that came out in March.
Yeah, I think when I wrote about it, the title I gave it was "The New Guidelines for Cholesterol Management Align More Closely to the Optimal Approach to Preventing and Eliminating Heart Attacks." So that aligning more closely to the optimal approach means they agree more with me, what I've been saying for the last 10 years. And they've done that compared to the big guidelines that came out 2013, 2018, is that they have put more of a focus on these biomarkers that we are going to talk about in a little more detail that aren't routinely tested, using cardiac and vascular imaging to identify early disease. Overall, moving towards earlier detection, meaning starting testing at age 30 at least,
Yep.
and looking at lifelong risk reduction. What is your risk of heart disease over 30 years, and how can we lower that, even though your current risk over the next 10 years isn't that high? Maybe we should start early and be more aggressive. And my feeling is that if we move towards these goals, we have the potential for totally eliminating atherosclerotic disease. We have great ways of lowering cholesterol. And when we do that, in the patients that follow these aggressive goals, in my experience, they don't have heart attacks, they don't need stents, they don't need bypass surgery, and they don't drop dead. So moving towards this more aggressive approach, earlier detection, lifelong risk assessment,
Yeah.
more aggressive treatment goals is a good thing. I think it's a good thing.
Oh my God, it's a great thing.
A lot of people have criticized this as an overreach. And I think, although I'm the skeptical cardiologist, I think in this area, because I've been looking at this closely for 30 years and seeing patients come to me who have already had their heart attack, so many, and had stents, that if we just intervened earlier and more aggressively, these patients wouldn't be in my office. So in this area, I'm a little bit ahead of the curve, in terms of the science, but I think the fact that the guidelines have joined me
Yep.
makes me feel better.
Oh, yes. Oh, it's a very, very exciting time. And of course, we just need to make sure everybody gets on board. It'll be a slow process, sure, including the medical community. As you just pointed out, not everyone was plotting it the way that you are and I am as well as a patient on the patient side. But so you're saying really one of the biggest shifts is the newer risk calculations,
Mm-hmm.
which you just pointed out. And then that's changed. And with regards to who would get treated earlier, I mean, someone conceivably could, based on new testing and new risk calculations, could start on a statin, for example, much earlier than we had been doing in the past, correct? For example.
Yes. And there's some nuance to that. These new risk estimators I don't necessarily embrace them. So the new risk estimator is called Prevent. And the way that we've done for 10 or more years was called the PCE pool cohort equations estimates. And basically, what they do is they look at all the standard risk factors that we traditionally measure: blood pressure, cholesterol levels, smoking, diabetes, age, gender, and they come up with a calculation of your percent chance over the next 10 years of having a heart attack or a stroke.
Mm-hmm.
And then they try to put that into different categories. For example, over 20% is high. In the past, under 7.5% was considered low with the old equations. So the Prevent calculations tweak the things that go into it a little bit. They've taken race out, even though race is a significant determinant of risk. They've added, I think it's a social equity estimate, which I think comes from risk from zip codes. I haven't personally used Prevent in my patients. I'm still using the old pool cohort equations. But anyway, when you use Prevent and add in all the different things, you come up with a lower estimate compared to what we would get from the other one. So it might be half So if you had previously estimated 10% and thought that patient definitely needed treatment, now you're coming up with 5%. And if you use the old percentage guidelines, you would not start that patient on treatment or recommend it to them. So when people have looked at that, they realize that perhaps 50 million people now would not be considered for treatment. And is the wrong way to move, because we want to start more people who need it on treatment. And so that's where a lot of the criticism of the new prevent guidelines comes from, is that the numbers are lower. And as a result of that, they're now talking about lowering the percent risk to 3 to 5%, where we start having a discussion about statins.
Wow.
This whole area, I would say, is in flux. And like I said, I have not fully embraced prevent. Primarily, I use these risk estimators as a kind of a starting point for a discussion with a patient.
Okay.
And then we have to factor in a lot of other things that affect the risk. And so that number becomes less important when we start thinking about other things. Like in women, there are some non-traditional risk factors, that they had gestational diabetes, gestational hypertension, if they had an earlier menopause, and if they have inflammatory disorders like systemic lupus erythematosus, that increases the risk. And we have to use a clinical assessment of all of these things mixed in together with what the patient preferences are in terms of how much they want to avoid having any heart disease 30 years down the line versus how much they don't want to take a pill, or how much they fear the medications. So I think it's complicated, and I can't totally sign off on the prevent equations at this point.
Okay. And another big headline is that treatment goals are back, which is tying into what you were saying. And walk us through that. What do the new cholesterol goals mean for the average woman trying to understand her numbers?
Yeah, so the overarching goal and theme of these new cholesterol targets is that the more plaque you have built up in your arteries and the higher risk you are for heart attack and stroke, the lower we want to get your LDL and ApoB, the atherogenic, if you will, particles in the blood.
We'll be getting to those in a minute specifically.
Yeah. And so I've been moving towards these goals for the last 10 years. The European Society of Cardiology came out with a similar, for high-risk patients, goal of less than 55 for LDL. For patients who have had heart attacks or strokes, it should be less than 70. The majority of people, if we're talking about primary prevention, we'd like to see the LDL less than 100. I think the new guidelines have moved towards these same numbers now. And the change is that after the 2013 guidelines, the idea was people who've had a heart attack, just put them on a high-intensity statin. Now, and this is, like I said, I've been doing this for 10 years. Now we want to try to get them down lower. If the high-intensity statin doesn't get them down below 55, then we need to add something else to get them down there. And so what these imply is that we're going to be using more combination therapies with a lot of these newer drugs that we have that are very effective on top of statins or in place of statins.
Right. When you say high intensity statin, what is that about? I mean, it's more than 10 mg a day. It's 20.
So it depends on the kind of statin. I predominantly use rosuvastatin because I think it's the best tolerated and most powerful and has the least interactions with things like grapefruit or other medications. So rosuvastatin high intensity is considered to be 20 to 40 milligrams. Low intensity is 5 to 10. For the most part, I start patients on low intensity because I want to minimize any potential for them having side effects and stopping early. And then we adjust upward or add a second agent if needed to reach our goals. Atorvastatin, also known as Lipitor, at 40 to 80 milligrams is high intensity. 10 to 20 is lower intensity. And then there's 3 or 4 other statins, which we probably don't need to get into unless you want to.
maybe we'll get back to that. Right now, I want to get to, something that I've been talking about with experts on the show for the last last 2 years. I've had cardiologists come on, first talking about statins, of course, and then the pros, the cons, mostly pros, and then specific tests that are just not being pushed enough or discussed enough, I really should say, with cardiologists or PCPs with patients. And now, of course, the great news, as far as I'm concerned, the great news that these new guidelines are strongly urging people to get these tests. And like I said, I've had people come on and specifically the calcium score test, the CAC, the Lp(a) test, which in Europe, my cousin in Europe, she got it once in her life. They have everybody get it once in their lifetime because, as you will explain a little bit, it is a genetic biomarker. And at this time, there isn't a lot you can do about that. But I know that there are some drugs that are in the pipeline, I think especially from Eli Lilly. And in fact, one of the people involved, one of the cardiologists involved in that was on the show. And then the ApoB, ApoB test, ApoB test. So those three are really critical because they really do give doctors like yourself a much better, clearer picture of your patient's overall heart health and potential for cardiovascular disease. So was thrilled when I first saw this back in March. So let's talk a little bit about that. And while I am not a doctor myself, I feel so validated because really on my show, when I had my experts on talking about each one of those three tests, I would urge my audience, just take print out, even give them a printable thing. Here's what you want to ask your doctor for during your next go round of testing. Take it with you, discuss it. So I'm really very happy about this. So let's take each one. So let's first go with the calcium, the CAC, the calcium score test.
Okay.
Fascinating, because you gave an example before. I just want to circle back to it, where when I asked about blind spots, and you could be doing everything right, eating right, exercising right, feel good, and then all of a sudden you could drop dead, which is what an example that one of my cardiologist guests shared with us. A friend of hers who was a runner, fit, and she had such a high score and had so much plaque built up in her artery. But you don't know that unless you get that test. So now please tell us about the CAC and your view of this new recommendation.
Yeah, well, I would say kudos to you for being on the cutting edge there with respect to those three factors. Those are three key factors that I've been promoting for 10 years on my blog and on my Substack more recently.
Thank you.
You've had Dr. Navar on your podcast, and I am like 100% agreement with everything she said. She did a great job, I think, of summarizing lipoprotein(a) and lipoprotein B.
Mm-hmm.
With regard to coronary artery calcium, it is a tremendous tool because it allows us to see the disease that we are trying to prevent or stop. That disease is atherosclerosis, which causes atherosclerotic cardiovascular disease, which is strokes and heart attacks, the things that require stents, the things that block off our arteries to our legs. That disease, we're not really looking at with any test when you go into your doctor's office. When you're getting your cholesterol checked, you're just looking at a surrogate. Cholesterol is important in the cause of that disease, but we don't know anything about what's going on with that disease in your arteries.
Right.
So it just makes complete sense that if you want to start treating a disease, why not find out where you're at with that disease? The only reason we're concerned about cholesterol is that higher levels cause more plaque cause more heart attack and strokes. If you have high cholesterol, but you have a zero calcium on your calcium scan, then you may not need any treatment. You
Right.
could be taken off a statin, especially if you're 65 years of older as a woman.
Yep.
With coronary, should I explain what a coronary artery calcium scan is quickly, or
Yes,
do your
please.
readers
Yeah,
are very
absolutely.
familiar with that?
Well, I know I've talked about it a lot and posted about it a lot, but I do think a
I can give
refresher.
you my
Please do.
30-second spiel on it. So it is an X-ray, a CT scan that
Easy peasy,
uses.
everyone.
And those who've had it, year one, know that it's a very simple test, 10 minutes, maybe no IVs, and some ionizing radiation, more than a mammogram, but not considered to be a dangerous level of radiation. And that's it. Hold your breath, and we take an X-ray of the chest, within which is the heart, and on top of the heart are the coronary arteries. And calcium, if it's deposited in those arteries, shows up very clearly on a scan. It's a very highly reproducible, accurate scan, unlike other imaging tests that I can talk about. And we know exactly what is average for, say, a 60-year-old woman. And if you have a score that is above what the 75th percentile for, say, a 60-year-old woman, we know that you have advanced subclinical atherosclerosis. You've built up more plaque, and you're at higher risk as a result of that. And we know that higher scores correlate to higher risk of dying, higher risk of cardiovascular events. And so it's like, we're looking at disease, and it is a predictor. And when we add that into the classical equations, this new prevent equation, we can come up with a much better estimate of your personal risk. You could be much higher.
Yeah.
Or you could be much lower if you have a 0 score.
Yep. And 0 is possible. I mean, I know women my age who have 0. I do
I've
not
seen
have
a lot
0.
of women
I
in
have
their
18.
60s.
Yeah. I mean, and I got this test 2 years ago, right after Dr. Navarro was on the show. I did go out and get it. Actually, it was a conversation I had with Gretchen Reynolds, who was at the New York Times and then moved over to the Washington Post as one of their health writers. But I did get it. And so it was 67-ish, and it was 18. And that was enough for my cardiologist to say, I'm putting you on a low, as you defined it, a low statin, 5 mg. 18's pretty low, but it wasn't 0. I was shocked.
There's a database called the MESA, MESA, all caps, database. If you just Google MESA CAC, CAC, or calcium, you'll come up, and you can plug your number, your age, your gender, and your race into it, and it will tell you where you stand in relation to other 67-year-old women. It will show you your percentile. And like I said, if you are at the 50th percentile for your age, then it doesn't move the bar one way or another. It just tells you you're at average risk. If you are above the 75th percentile, it can double, triple, or quadruple that risk estimate. And the MESA database, if you plug in all your other stuff, will give you a risk with and without that. And we often see that double or triple or go down by half. It personalizes the risk, and it helps give more information to the patient to make a decision either to go with treatment at this point or work more on lifestyle. And it's very helpful.
Yeah. Yeah. I mean, in this case, the cardiologist believed I couldn't be doing anything better lifestyle-wise for me. So, the low-grade statin. Now, is this a test, the CAC, do you think people should get again? Or is once enough?
If you have a non-zero calcium score, then it is not helpful to repeat it. It's going to go up, whether you start statins, whether you start PCSK9 inhibitors, or whether you do nothing, it's going to go up. And because what we're looking at with the calcium is a late stage phenomenon. We're not really seeing the early plaque in the coronary arteries. When the plaques start, there are little fatty streaks in the lining of the arteries. As more cholesterol gets into it, it builds up and becomes a fatty plaque that does not have calcium in it. But as inflammation progresses, little osteoclasts in the cell lining in the arteries of the heart start depositing calcium. So it's like we know there's been a lot of problems there by the time calcium comes in. And that brings up another point. I don't know if we were going to talk about it specifically, but in younger people, coronary calcium score can be 0, and you can still have significantly more plaque than you should have if you have soft plaque.
How is it determined whether it's soft plaque or hard plaque?
It's based on the radiographic appearance. There's something called Hounsfield units.
Okay.
And calcium has Hounsfield units over 130, I think it is. And so it's the X-rays are very much absorbed by the calcium, whereas fat, it's much lower. It's a total different density. So calcium just stands out like a sore thumb on an X-ray. Just one other thing, because I don't know if it was in your list of questions, is that I've become a big advocate of coronary CT angiography in patients in many situations. It's definitely useful and indicated if you have chest pain. It's like the calcium scan, only we add the intravenous infusion of a contrast material, and it's more elaborate. We have to take more pictures, takes a little bit more radiation, but it allows us to see the complete arterial tree. We can see whether there's any blockages there. We can see soft plaque. We can see calcified plaque or hard plaque, and we can quantify using new AI tools, one of which is Clearly, another one is called HeartFlow. We can quantify, give you an absolute number of your total plaque burden and the percent blockage in any of the arteries. So if you have symptoms, it's definitely, I think, the way to go. But it's also useful in the younger people who have a 0 scan, but we're still worried that they might have built up more soft plaque than was expected.
But who should get that? Should I get that?
I offer it to all my patients, but we have a good discussion about it, about what it's going to add in their particular case, why it might be useful. If you want to know 3 years from now, what's going on with my coronary arteries? How is that question going to be answered?
Yeah, well, then...
What's your doctor told you you're going to check in 3 years?
To do another CAC in 3 years?
That's not a good idea. That's just going to go up.
That has not been discussed. As far as the cardiologist is concerned, I'm not getting another CAC unless I put my foot down and demand it. But I see no reason to do that.
Well, that wouldn't be helpful. Another CAC would not be helpful because it would just show a higher calcium level.
Okay, exactly.
But if you had gotten a coronary CT angiogram with, say, a Clearly analysis, which quantified it, then 3 years from now, you could compare what's happened to the soft plaque before and after and get an idea of how well the therapy is working for you.
Got it. Interesting. Well, now my poor cardiologist is going to get a little phone call after this.
Well, it's not going to be covered by insurance. It's going to be, depending on where you go.
Yep.
The coronary CT angiogram out of your pocket could cost anywhere between $500 and $1,000. And Clearly, the AI quantification on top of that could be anywhere between another $500 and $1,000. So,
no kidding. Wow. So it's really probably geared more towards people who are feeling some symptoms.
Definitely if you have symptoms that you're concerned that it might be due to a blockage that's developed, it's great. I consider it the premier tool, and it will be covered by insurance.
Mm-hmm. Then it would be. So, but if it's just someone like me who has no symptoms, really my numbers are quite excellent, blah, blah, blah. Even the 18 is not so terrible. It would not be covered by insurance.
Prior to the advent of the AI quantification of coronary CT angio, what I told my patients when they asked me that question, I've been on treatment now for 3 years. How do we know we're doing any good? Should I get a stress test? I don't think a stress test is a good idea for anybody who's not symptomatic because there's too many false positives. And if it's normal, it doesn't really tell you anything about the plaque burden. But now I tell them, well, if you really want to know what's going on, we can do a coronary CT angio.
We can do that.
Compared
Okay.
to one you've had before.
Yeah. Well, I find that fascinating. I love doing those kinds of tests. I really, but no one's mentioned it to me yet.
I have many patients who love doing those kinds of tests.
Yeah. I really like knowing what's going on in my body. I do.
I think I may attract patients who really want to know what's going on, but because it's an inordinately high number that are interested in things like that.
So word of mouth. Word of mouth. See, people are telling each other like, hey, you want to get that test?
Yeah.
Come on, I'll tell you who to go to.
Yeah.
I think that's so funny. All right, let's move on to another test, which is so important. And we referenced it already. It's the Lp(a). You did say Dr. Navarre, Anne-Marie Navarre, wonderful, wonderful cardiologist. Yeah. And she actually is involved in that Eli Lilly drug, which I think is out or almost out. I really don't recall, because in the past, this is my understanding, according to Dr. Navarre when she was on the show, the reason why we haven't been pressing people or doctors to offer it or people to get the blood test as they're getting their annual physical, is because whatever the number was, there wasn't much you could do about it. I mean, even if there isn't a drug to fix it, of course there is. I mean, if it was bad, if the number was a terrible number and you do have a genetic component there, I mean, aren't you going to be even more serious about lifestyle changes and so on? Of course. I mean, I'm hoping. Yeah. So I never really understood that, which is why I was so excited when I had first read about it in some medical journal, found Dr. Navarre, got her on the show, and this is well over 2 years ago, and talked us through it. And of course, then I got the test as well. Thank goodness, yay. It was quite good, quite normal, so I don't have that genetic component. And in Europe, as we mentioned, they're already doing it, just standard. I just never understood that mentality. So this is really good news. Now talk us through it a little bit about the Lp(a), please.
Yeah, so lipoprotein, parenthesis, little a, end parenthesis. And even if, one thing I've noticed when I've been ordering lipoprotein little a, unless you put the actual code for Quest and LabCorp on there, they may give you apolipoprotein, big A.
Another one,
which is nothing
also,
to do with
not
it.
like this, but also good.
I don't think that adds anything. I don't think apolipoprotein B is good, but apolipoprotein A.
But the ratio, don't you do both and then there's a ratio between the two? Isn't that important? But I mean, we could go deep in those weeds if you want to.
Yeah, I mean, it gets down to tests that are very marginal in terms of what they add. But lipoprotein little a, I think, is very important to check at least once in your lifetime. And I've been doing that for probably 10 years. The new guidelines endorse that. Yes. And the reason is, this is, as you said, it's an inherited factor. One of your parents had it. It's a gene, and it's also a protein. It's a protein that sits on the LDL, the bad cholesterol that carries cholesterol in your bloodstream, and it's much more toxic than the normal LDL. Having high levels of lipoprotein A confers a 2 to 3-fold increased risk of heart attack and stroke, also an increased risk of something called aortic stenosis due to aorta, due to calcification depositing in your aortic valve. And you're born with high levels. They don't change much through your life. They're not related to diet or lifestyle. But as to why it's important to check, something that we right now don't have a specific drug for, I think you're spot on. Number one, it tells us that you're at a higher risk. And because you're at a higher risk, we're going to put you into a higher risk category, and we're going to shoot for lower goals for LDL and ApoB. And we're definitely going to be looking at your calcium, because we want to know what damage that's already done to your arteries. So we're going to definitely, if you've got a high lipoprotein A, you should get a coronary artery calcium scan. There's a couple other things with it I think are important. One is there are ongoing research trials. You can enroll in them. Several of my patients have. I wrote about one of those trials on my Substack. I think that trial is now closed, but I kind of stay on top of that and will inform readers as things come available. The other reason is you should tell your children, you should tell your brothers and sisters that they might have a high lipoprotein little a. They need to know that very early on before they drop dead from their heart attack caused by the high lipoprotein little a.
Question. Given the whole conversation we've had so far, I have 2 daughters. One is 32, almost. She's 31, and 28, my other daughter. Do you think they've had the LP little a test?
Yes.
Of course they did. Okay, continue.
You're on top of things there. And then I tend to lean toward, there are a couple of drugs that actually lower lipoprotein little a that are approved, but we don't have studies showing that they specifically lower risk in that population. One of them is niacin, and I am not a user of niacin and have not been for 15 years since a trial showed that it actually worsened cardiovascular events. And so I think I don't recommend that niacin. It's also hard to tolerate. The other drug is PCSK9 inhibitors like Repatha and Praluent will lower lipoprotein little a about 20%. We don't know for sure if that is also lowering your risk, but it's definitely lowering your ApoB and LDL a lot, and we're pretty certain that that is lowering your risk. So I move much more quicker to those kinds of drugs in patients like that, and I have significantly lower target goals for patients with high lipoprotein little a, usually less than 55 for the LDL.
Yep. No, it's really fascinating, and I'm really, again, so very happy that the new guidelines are strongly urging people to get that test at least once. Let's go over to the ApoB, ApoB for short. Talk to us a little about that. I did have a whole episode focused on it with Dr. Navar also, but if you can just refresh our audience's memory about that.
Sure. So ApoB, apolipoprotein B, is a kind of lipoprotein. So those particles that have cholesterol on the inside and they have little protein things on the outside. It's a protein that's attached to lipoproteins. And it's attached to not just the LDL, it's attached to VLDL and IDL, the remnant lipoproteins that are also contributing to the risk. These are the atherogenic lipid particles. And when they have an ApoB attached to them, they're much more likely to get into the lining of the artery, get oxidized, cholesterol, inflammation results. And that's the process of atherosclerosis is triggered by particles that contain ApoB. So if we want our best measure of the atherogenic potential, the potential for buildup of plaque with these particles, the ApoB is the best number for that. And most of the time, doctors are not measuring that. But it's very useful. It's inexpensive. It's reproducible. It's a good test. And I always add it onto a lipid panel because it is a little better predictor than LDL of what your risk is. Sometimes they're discordant. You have a high ApoB. It's often in patients with insulin resistance, diabetes, due to these remnant particles being higher. And that ApoB in that situation predicts risk better than the LDL does. And especially on treatment, they can become widely discordant. And we want to get that ApoB down as well as we're getting the LDL down, especially in high-risk individuals. So ApoB, I think, should be measured. I typically measure it with every lipid check. I don't know that it has to be with every lipid check, but if you're stable and you've been at gold, you might just check the LDL, but I do recommend that.
For me personally, I mean, since Dr. Navar was on the show talking about the ApoB, I've had 2 annual, because it was over 2 years ago, I've had 2 annual physicals. and the lipid panel, of course. And the ApoB has been tacked on to both of those. And those are just, my doctor understands this is going to be a regular thing now.
Yeah.
It's
good
going
for
to be
you.
part of my lipid. Absolutely. And that leads me to my next question. Really want to know, you're sitting on the other side of the desk, and maybe even with these new guidelines that everybody knows about now, maybe some doctors aren't going to be as quick to adopt them as we would like. So I think people always need to be their own advocates and really be a little pushy about these things. So let's assume somebody listening now is going to be getting their annual physical and wants to get this done. Should they go in and just ask, even if they're normal right now, even if their HDL, LDL levels are okay, shouldn't they just go in and say, I want these tacked on to my next lipid panel and I want to schedule that CAC?
I would say definitely add those biomarkers. And the other biomarker, I don't know if we're going to talk about it, is high sensitivity CRP.
Absolutely. Well, I didn't have it in my notes to talk about, but I'm so glad you brought it up. Let's just talk about that really fast before you answer the question about how do my listeners approach this with their doctors. Because I get that too. I get the regular CRP and I get the HR one. Okay. So please explain. For inflammation.
I saw that you were recommending getting both, but I don't think there's any benefit to getting the CRP if you're getting the high sensitivity CRP. I think you're measuring the same thing. The high sensitivity is going to get lower levels, be very sensitive to very low levels of inflammation. But as we talked about, when the ApoB lipoprotein gets into the artery, the lining of the artery gets oxidized, then inflammatory cells come in and start this process of atherosclerosis. That inflammation can be measured. If you have a lot of this going on in your coronary arteries, then this high sensitivity C-reactive protein, HSCRP, is going to be elevated. We've seen that as a marker in a lot of patients who had diffuse plaque that was in a very inflamed and vulnerable state, meaning highly likely to rupture and cause a heart attack. And when we treat cholesterol, get that down, we see those markers go down accordingly. So I generally will measure that at least once, and most of the time I'll measure it. If it's ever been elevated in a patient, I will remeasure it and make sure it gets down. And there are now specific drugs targeting those who have coronary disease, have had heart attacks, and have an elevated CRP, colchicine, which has long been used for gout.
Yeah, I was just going to bring it up. We're really going down in the weeds in such a great way right now, and I so appreciate this.
Sure.
But I don't know if you caught that episode, but I had a wonderful episode specifically on inflammation, what it is, how it affects so many different parts of our bodies, and with a real focus on heart health. And the researcher that I had on from NYU Langone Health in New York City, she was talking about colchicine and the ongoing tests about that. Correct.
Yeah.
What are your views on that from the studies you've seen?
There's a good study supporting colchicine in that kind of patient that I described to you. It's not for everybody, but if you have high risk you've got your lipids optimized, you're at goal, and you still have this high sensitivity CRP up in colchicine, I definitely prescribe that. And we see the CRP come down with that, and studies show it lowers the risk. It's a pretty well tolerated drug. I use the generic cheap version of it. And yeah, it's another tool that we have to just take coronary disease off the table as something that kills people.
And this is such a great example of yet another medication that was originally, it was for gout and still is, I shouldn't say was, still is for gout. And then, another use was found for it. But you don't believe, even if the numbers are good, for people to take it prophylactically?
No, I don't see the evidence supporting that. No.
Okay. It's very, very ongoing. I mean, there's still a lot of research that even this doctor that I had on the show it's ongoing information. Anything else? Any other tests that we didn't cover that you think my audience should really pay attention to?
Yeah, I mean, but you asked me, I think, and I don't know that I answered about what women should ask about.
Right. Let's get to that.
When
What do you
they go
recommend to
in.
them?
Well, and then how they should do it. I mean, I think if you want a test and you have good reason for it, you should be able to get that test unless it's expensive. And if it's expensive, then you can decide if you want to pay that expense. But these tests are not. ApoB, CRP, high sensitivity CRP, and lipoprotein (a) are inexpensive tests. They're easy to add on to a blood draw. So if your doctor objects to this, maybe find a new doctor. Maybe
Call Dr. Pearson.
it's more up on things and is willing to take your information into account. Whether you should push for a coronary artery calcium scan, I think as long as you really know that it's warranted in you. Now, there's some people it's not warranted in. If you've had a stroke or a heart attack, we already pretty much know that you need intensive lipid lowering therapy and risk factor management, global risk factor management. So how much a calcium scan adds to that kind of person is debatable. If you are 30 years old, it's extremely, extremely unlikely that you would have anything other than a 0. Now, you can always make the argument, well, if I'm the 1 in 200 that might have a non-zero, I want to know that. But if you really want to know at that very early age, then you might want to consider a coronary CT angio as opposed to a CAC, because that's much more likely to pick up disease. So I can't say that everybody should walk in and ask for one, but you can always say, Doctor, do you think I would get more information from a coronary artery calcium scan? And gauge what the response is. And I would say that the majority of people where we're on the fence about taking a statin, about starting medications, they'll benefit from getting that additional information and helping make that decision and making a more informed decision about what their risk is and what the benefits of the drugs that they're going to be put on.
Yeah, I want to get your input on statins in a minute because they've gotten such a bad rap. Like I see so many things on Instagram and whatnot talking about statins and all the evils of statins. I just want to get your input on that. But getting back to the CAC, I mean, I would bow to you. Of course, you're the expert. I am not. All I know is that when Gretchen Reynolds, she's quite famous, a health journalist that was on, and told the story about her friend, which I mentioned before, who was a runner, her runner buddy, and just dropped dead of a heart attack. And she had a CAC. They would have seen it. And of course, then Gretchen ran out and got a CAC within a week. Her husband made her do it. But the point is, like, I just feel like, why not? Like, what's the downside? Except a little bit of radiation, and a little cost. And it's really not, as you know, not expensive, even if insurance doesn't cover it. And insurance very often does. And we're also talking about an age range. We're talking about women in their 50s, 60s, 70s. Probably insurance will cover it. It covered it for me 2 years ago.
Well, I would say, I mean, there is some definite, not going to be helpful. You've had a stent, it's not going to be helpful.
Yeah, exactly.
You've had a massive heart attack, it's not going to be helpful. I want your LDL down below 55, irrespective of what your calcium. I know your calcium score is going to be high, really high. And even if it's not really high, I'm still going to want an aggressive goals. But probably 95% of the people that come to me and we want to talk about prevention, they're going to get a coronary artery calcium scan from me.
Yeah. I just really urge everyone to just give it some serious consideration and discuss it with your doctor. I would like to nag everybody listening in, always with love in my heart. Always, always with love in my heart.
And I would say also that When patients ask me, do I need this? Should I do this? Can I take that? I'm always open. I view it as an opportunity for education, for getting more information. Sometimes I learn when they ask me about things. So if your doctor's kind of gets angry with you, like I said, find another doctor.
Yeah, that's true of like almost every category of medical care I could think of. It's like if you're not being heard and if you don't have a partner in your healthcare provider, whatever that specialist is, you need to find somebody else for sure. Somebody like you, Dr. Pearson, who clearly is open and listens to your patients. You even said that earlier. Like you want to know, like, how do they feel about medication? How do they feel about what their risks could be down the road? Maybe they don't care that much. I mean, you have to listen to them and have a conversation. Not always easy. We know that.
Well, the current medical system for primary care physicians is very difficult. I mean, we're talking 20-minute visits covering every organ system, every symptom that they might have. It's very, very hard.
Very tricky.
To have these kind of conversations. Now, in the last 4 years or so, I've moved into a system where I can spend all the time I want with patients. I mean, it's not economically sustainable for the vast majority of cardiologists or primary care doctors, but when you have that, then you can have the kind of discussions that are probably needed in each and every time.
Yep. Yeah. Thank you for that. So statins, I mean, again, they do get a bad rap on occasion. I have had an incredible expert on, cardiologist who specializes in statins and other medications, talking about the power of statins. I mean, she's team statin. And I found the conversation really incredible. I mean, she explained in layman terms what a statin does, what some of the side effects could be, not always, some of the ways to mitigate those side effects, like taking CoQ10, for example, for any muscle pain or what have you. So what are your views on statins in a kind of a general way? Do you think that they're like God's gift to the world? As one doctor I know who hasn't been on the show says everybody should be on a statin.
Well, I mean, I usually say something like, we've been using them for 30 years. We have studies on hundreds and hundreds of thousands of patients showing that they are very safe and very effective at reducing heart attack and stroke risk. And we now have generics that are available once a day, very low side effect profile. So when I go into my statin spiel, I'm really positive about it. I usually don't even broach the topic of statins until I've been talking to the patient for a fair amount of time and got a good feel for where they're coming from. And rarely on the first visit, I want to establish trust and rapport, because so many people have heard things that are incredibly negative about statins, and they already have it in their head that this is some sort of collusion between big pharma and physicians. Physicians are making all kinds of money off statins, which is just absurd. I mean, rosuvastatin, you're probably maybe paying $5 a month or something for it. Nobody's making huge amounts of money off these generic statin drugs. That being said, there's some people that have been so convinced that they are dangerous. And often this is people who might be in the keto community or people who are very much into alternative medicine. I see a lot of them in my Encinitas office. It's this kind of alternative medicine, cure everything with supplements is very powerful in this area. And as a result of that, I've started writing and looking very closely into supplements for cholesterol, just so that I know that I've looked into the ones that work, the ones that don't work. But Yeah, statins are great. And they should be our first line choice because they're so cheap, they're so safe, they're so well studied. But if a patient has a problem with statins, I do not try to push it on them at all. We move on to the other options that we have.
And there are non-statin options. You mentioned a few during the course of this conversation so far.
Yeah. And, ezetimibe or is now a generic. It's cheap. It's once a day. Incredibly low side effects. Sits in the intestines, prevents the reuptake of cholesterol, the absorption. It stops the absorption of cholesterol. Works in a totally different way from statins. That's it. If you want to start off with something that is like incredibly safe, try that. And then if you want to go the Repatha, the injectable route, these are great drugs. They seem to have less of it seems in the keto community, for example, people are more excited about getting Repatha. I think because Peter Attia is a big fan of it.
Excuse me, but are people still listening to him? I don't know. Maybe.
I would like to know that myself.
I'm really curious about that. You should put it out there. I nominate you, Dr. Pearson. I nominate you to put it out there on the Substack thing and I'm just doing a poll, just a little poll. Like, are you guys all still following him? Look, he still has some pretty good stuff that he puts out. You just have to, I guess, forget, which is hard to do. I do find myself scrolling past him now for sure.
Yeah, well, I totally get that. He has put out a lot of good stuff. And in the area of cardiology, I wrote this about a year or so ago on his Outlive section on the heart. And he's basically advocating primordial prevention. He's very much a fan of ApoB, lipoprotein(a), and he wants you to get your LDL down into the 20s, where it was when you were a neonate, which I think is a little excessive.
I think it's a little excessive. I just don't think that's realistic, right? For most of us.
It's not. It's kind of crazy, but it's typical, I think, of Peter Attia.
And that whole, we call the bro mentality, right?
Yeah, definitely.
Are you by any chance watching that new CNN that just started with Kara Swisher? Kara Swisher Wants to Live Forever?
I haven't seen that.
Yeah, you should check it out. The first episode aired, and it's all about this.
Okay.
It's all about, like, she interviewed Brian Johnston, the one who takes 1 billion supplements a day and does these crazy things. It's very interesting, just talking about this whole kind of mentality. Sorry to interrupt you.
Well, moving back to the other drugs that we have. So in the area of PCSK9 inhibitors, a study at the ACC meeting last week used an oral version of Repatha, PCSK9 inhibitor, and showed a reduction in events and a dramatic lowering of LDL. So soon that will be available, probably by the end of the year, that you will have a pill form of these very effective drugs as alternatives to statins.
Now, are these only alternatives, or are they also sometimes used?
They're add-ons as well.
As add-ons too. That's what I thought, for high risk. Yeah.
Yeah, typically my patients will be on a little bit of statin, maybe a little bit of Zetia, and then we add the Repatha if we're still worried about residual risk. Or if they've had statin intolerance, then they might not be on a statin as well. Another drug is bempedoic acid, which works in the same enzymatic pathway as statins, but is not absorbed into the muscle. So you can try that in place of statins for people who've had muscle problems, muscle aches. It's not nearly as powerful as the statins, won't have nearly as much data. It's more expensive, increases your risk of gout, but it is an alternative. And then, as you mentioned, lots of drugs coming in the pipeline for lipoprotein(a). They're very exciting, very powerful. We just need to get some evidence that they lower events and don't have any weird side effects that we're not sure of. And hopefully in the next year or two, we'll get those lipoprotein(a) lowering drugs.
Right. We're living in a very exciting time for sure. So we've talked about the tests that people should get or should consider getting, and certainly should consider discussing with their trusted healthcare provider, cardiologist. We talked about medications that exist, and then you just alluded to some coming down the pike, and hopefully we'll see more. And more research, of course, is always being done. Like we mentioned, the colchicine for inflammation and the like. So it's very exciting. And you're keeping an eye on it. Of course, I keep an eye on it in my own way as best I can in getting the information. But aside from that, what I really want to focus on now briefly is, what do you say to your patients with regards to lifestyle? What should everybody be doing every day?
Everybody should be doing 150 minutes of some sort of cardio fitness routine for a week, like 5 30-minute episodes. And that should be moderate to vigorous activity. The more you get your heart rate up, you get a little bit short of breath. Everybody should be doing resistance exercise, 20 to 30 minutes, 3 times a week or so, to maintain their muscle integrity, especially as they get older, especially women. I don't think they have as much attention to that as they should have. I think they're getting the message thanks to sites like yours. It's good for bone health.
Yep. Oh God, I've been talking about that. I get nagging, again, with love in my heart, about bone health for years. From my first book that came out in 2010. I mean, it's super important. We could go on and on about the importance of bone health.
Yeah.
As it relates to aging.
Yeah.
And if you want
definitely
to age well, I mean, it's all important. It's all related too.
Yes. Yeah.
It's all related. Bone health, I mean, you do that strength training, you're helping your bones, building your muscle mass, of course, to support your bones, but you're also helping your brain and your heart.
Yeah, absolutely. Yeah. And there's a lot of kind of observational studies on cardio exercise and resistance in terms of actual randomized trials showing lowering of heart attack risk. We don't really have those, but I still think those are all great things to be doing for the whole body. And then in terms of diet, the major thing with both diet and lifestyle is not to have a large amount of visceral fat.
Yeah.
Not to be obese, which if you have a lot of visceral fat that builds up in the abdomen, then you get insulin resistance, you get diabetes, and those two things give us abnormal lipids and inflammation, and those contribute to heart disease risk. So maintaining an ideal body weight, which is usually the thing that's measured, is BMI, which is kind of a calculation off your height and weight. But if you wanted to be more precise about it, you could get a DEXA scan, DEXA, which is the way they measure osteoporosis and bone density. I often use that, recommend that in my patients if we want to have a good idea what's going on with their visceral fat and whether they need more resistance and cardio and less calories in to get that under control. So diet is the other aspect of that. What?
And also measure your waistline, right? Measure your waistline.
Measure your waistline. It's another tool. It's not as good as DEXA, but it's a lot cheaper and a lot easier.
You can do it yourself.
Yeah, you can also get skin calipers. I've done skin calipers. And there's a YMCA across the street from me here that has a program called eGym, which a lot of women your age are using. I think there's 1,000 people using it right now. It is a kind of a circuit of resistance machines, kind of gamified. It tells you how hard to push. It measures your strength and it tracks that over time.
Huh.
But as part of this program, and they're measuring your biological age. So they measure your strength age. They measure your metabolic age with an in-body bioimpedance scale.
I use that.
Do you?
Yeah.
I'm a fan.
Did you really think I didn't?
I'm a fan.
I go to the gym, and once a month I stand on my in-body thing.
Nice.
They let you do that. And then You put in your phone number and then I have all the information comparing. Yeah.
Yeah.
Oh, it's very motivating.
I know.
It's very motivating because I then set certain goals.
Yes.
For different things.
Mhm.
And, certainly for muscle mass.
Yes.
And I do what I can to improve it. And then when I see that it is improving, I give it a month because, any less than that is kind of ridiculous. Give it a month. And when I see it's working, that is motivating.
Yeah. Yeah, absolutely.
What do you think about that in body scale?
I totally agree with you. I mean, I get myself weighed over there periodically or tested on that periodically, and I can see my muscle mass is going up. I mean, this is great because it's supposed to be going down as I get older, and my body fat is going down.
Yeah, that is so great. Think about that. Isn't that motivating for you when you see an improvement?
Yeah.
And makes you want to do more?
I think the whole program is motivating. I mean, it has on the cardio machines, the ellipticals, the bikes, it can estimate your VO2 max, which is a measure of cardio fitness. And it'll give you basically your cardio age based on that. So, those are the three things that you want to be working on is making sure that your cardio fitness is being maintained, your strength is being maintained, and your metabolic status measured as represented by waist circumference or in-body bioimpedance testing. The ones that you get at home, I don't trust. I don't think they're good, but in-body is a good example of a good bioimpedance test.
Yep. Yeah, for sure. And then we could get into eating. I know you recently did something about your search for the perfect almond because you weren't so happy with the almonds that you had been eating. So very interesting. But
yes.
But do you want to just touch a little bit on some things that we maybe should avoid and certainly should be including?
Yeah. So, I mean, the bottom line on diet, I think, is you want to find something that's palatable, sustainable, and leaves you not overweight and not metabolically dysfunctional. And so various diets work for some people. Everybody's kind of different. So I've seen people do very well with keto diets, and you can modify keto diets if you want to get reduce the saturated fat and increase the unsaturated fat. Very low fat diets have worked for some people. My recommendation is a modification of the Mediterranean diet. The Mediterranean diet, as demonstrated in the Predimed study, did lower cardiovascular risk in a group that was supplemented with extra virgin olive oil and mixed nuts. So I think boosting up your extra virgin olive oil, your nuts, and kind of following that Mediterranean diet is a very good and sustainable, palatable approach.
Yeah, it really is. I would say add in blueberries. I know that's not specific to the Mediterranean diet, but it is in the MIND diet, MIND diet for brain health. And it's basically Mediterranean diet, but just I eat like a cup of blueberries every day, if not more.
I think I'm going to disagree with you on
okay, go ahead. Good. Well, because that is
the first time I've disagreed
why we call
with
you the skeptical cardiologist.
Yeah.
Why do you disagree with me? Go ahead.
I do eat blueberries every day, but
because they're also good.
They're good, and some of these things get into your head, and you're like, "Oh, blueberries are good," but all of that stuff comes up from observational nutritional epidemiology, which is the worst science. It's just associations. There's so many things that get associated with good health, and it's not necessarily because they cause good health. It's just because people who are healthy for other reasons decide that this is something good to eat. With respect to the MIND diet, there was a randomized trial of it on cognitive function, and it had no benefit whatsoever.
None whatsoever.
That's why I'm a big skeptic about observational studies.
Okay.
And lots of what comes out in diet, you'll see a different thing every month or every week, really, about this thing is especially helpful for you. This is not helpful. This and I wrote recently about processed meat and jamón ibérico and how really jamón ibérico is a carcinogen. It all comes from observational data. And when things are like that are put to a randomized trial and they're not shown to be beneficial, people still keep pushing them and writing books about them. So I have to differ with you on that.
Oh, no, and that's totally fine. And again, that is what we're counting on, that you're going to be looking at all of this and kind of setting us straight. So thank you for that. But I will continue to eat my blueberries because, hey, they're a berry, they're fruit. They're not going to hurt me as far as I know.
Well, yeah. And then
as far as I know,
we've also gotten the memo also that we should be consuming fruit every day, and berries have a low glycemic index or load. So if you're going to consume fruit, it seems like berries are probably a good one to be consuming.
Yeah, that's about the only fruit I eat. I have to be honest with you. Not on purpose, just like, I don't know, that's how it turns out. But I do make sure I get those blueberries in and that little piece of dark chocolate too. Of course, I always go with that. We could go on and on because I have so many other questions for you. I have so many. So, Dr. Pearson, will you come back so we can continue this conversation?
I would be honored to come back, Barbara.
Because I really do have a lot of other questions. You know, we've run out of a little bit of time. Before that, I let you go because no one has ever been on the show in 4 years and has been able to leave without answering this question. And that is, what are your 3 top takeaways that you really want to make sure everybody remembers? Because we covered so much. And as I learned early on in my career, early on and back in my 20s when I was giving presentations, people don't remember a lot of what you tell them, but they do remember moments. So just give us 3 top takeaways so my audience will remember. And everybody, please remember to check out the show notes because there is a link to the Skeptical Cardiologist. I think based on everything you just heard, you really want to listen. You really want to read Dr. Pearson's The Skeptical Cardiologist Substack. You really do.
Thank you.
All right. So what are your 3?
Big 3. Recognize that cardiovascular disease, atherosclerotic cardiovascular disease, is the biggest killer of men and women, and that it is a silent, insidious process that begins when you're in your 20s and slowly builds up. You may have a heart attack from it without any preceding symptoms while you're feeling great and following a great lifestyle. The second important point is that we now have ways to personalize your risk assessment for that disease. And that includes a combination of biomarkers that are now recommended for everybody, lipoprotein little a, ApoB, and CRP, high sensitivity CRP, combined with imaging. And that imaging could be a coronary artery calcium scan, or we didn't talk about this, but I've written about this recently, ultrasound evaluation of your carotid arteries can show early plaque. That's useful if you have a 0 score on your coronary artery calcium. And the third thing is we have tremendous ways of treating this disease, this atherosclerosis that causes heart attacks and strokes. We have all kinds of choices in terms of medications, and we know what to do. We know what goals to take you to, and we need to get you there early before you have disease, before you have symptoms. And if you have a problem with a statin, which you shouldn't have because they're great effective drugs, we have alternatives to that.
That's great. Thank you so much. One thing I just wanted to add in to the lifestyle choices is everybody, if you are still smoking, don't smoke. Stop smoking. If you can't stop smoking, get some help so that you can stop smoking. I think it'll help a lot. Yeah.
Absolutely. I think I had that down here somewhere. Yeah.
And I'm going to put in one more plug.
Smoking cessation was number 1 on my list.
I really think it's because It's hard to believe, but there still are people who are smoking.
I know.
So don't. Do everything you can not to. And I'm just putting another plug to go ahead and get those tests done at least once. Dr. Pearson, I can't thank you enough. This was a great conversation. It was also a lot of fun.
Enjoyed it.
I really do hope that you'll be back.
I definitely will. It was a lot of fun.
Thank you so much. And everyone, thank you for tuning in. See you next week. Thanks for tuning in, everyone. If you enjoyed this episode of Age Better Podcast, please do a few things. First, share it with all your friends and family. Then, subscribe to Age Better wherever you listen to podcasts, including YouTube, so you never miss a single episode. Finally, if you have ideas for topics you want me to cover in a future episode of Age Better, send an email to agebetterpodcast@gmail.com or reach out to me on social media. Until next time, remember this. We can't control getting older, but we can control how we do it. Talk to you soon. Age Better Podcast is a proud member of the Sound Advice Network. Sound Advice, women's voices amplified.